And the question I want to try and answer today is, should we move from glycemic markers to direct measurements of glucose, which practically means should we move from HbA1c to using continuous glucose monitoring? And the reason why that is important is because we think that HbA1c is unreliable in the CKD population, which I'll show you some data on in a minute. So the questions I want to address is that hemoglobin A1c in the chronic kidney disease population. I'll talk about glycated albumin and fructosamine, which are two markers completely independent from hemoglobin A1c. And then I'll talk a bit about continuous glucose monitoring. And then finally, I'll return to the question, should we replace or complement HbA1c in the chronic kidney disease population? And I will use the abbreviation CGM, which stands for continuous glucose monitoring. So I'll use CGM. Okay, so chronic kidney disease, so we have 5 stages, and here in stage 3B and downwards, that's where things happen. So patients, due to lack of EPO, develops nephrogenic anemia, phosphate increases, and they develop acidosis and other problems. And here we have a cohort study from primary care of type 2 diabetics, and here we can see approximately 1/3 of them have chronic kidney disease in various stages. And approximately 6% are in the more severe stages where some of the physiological changes occur that may affect HbA1c. But I just want to show you briefly these very recent KDIGO guidelines. So if you don't know KDIGO, those are internationally very used guidelines in nephrology, and they recommend treatment for diabetes patients with CKD. And if you look at here, the first one, the CKD stage 4 and 5, including dialysis patients, they try to answer the question, should we use HbA1c in that population? And they write, yes, we should measure it, and we should do it twice per year. But they also write reliability is low. And they state that, but still recommend it. So why is the reliability low? So yeah, glucose binds to the beta chain in hemoglobin and forms A1c, which we can measure. But in these patients, we give them EPO, which stimulates bone marrow, the erythropoiesis. And that stimulates the production of young erythrocytes. And when we measure hemoglobin A1c, it's an average of both the old and the young erythrocytes. That means that if you have an increase of young erythrocytes that are less glycated relative to the old one, that can sort of dilute HbA1c down and be a confounder. So that's a problem. Historically, another problem with what is called carbamylated hemoglobin. So as creatinine and urea goes up, there's a waste product from urea called isocyanide that can bind to hemoglobin and interfere with the measurement. And decades ago, it would mean that HbA1c would go up, but with modern methods, this problem has been diminished quite a bit. But then what I think personally is a big culprit in terms of affecting HbA1c is the erythrocyte lifespan. So there are studies showing that when patients are in dialysis, the lifespan of erythrocytes are diminished. And why is that important? It is important because the glycation of A1c is a function over time. That means that if an erythrocyte lives a long time, more glucose can bind, and if it lives a short time, less glucose will bind, and that will affect A1c levels. And we looked at that in type 2 diabetic patients on hemodialysis, and we used a method called Chrome 51, where we took out 10 milliliters of blood, incubated with Chrome 51, which is slightly radioactive. Then we re-injected into the patient, and then we measured the radioactivity over time. And if an erythrocyte would die and break off, Chrome 51 would be cleared from the body. So we could measure the counts per minute as an indicator of erythrocyte lifespan. And here are the results. So here on the y-axis you have erythrocyte lifespan. Here we have the type 2 diabetics on hemodialysis. And here's the mean lifespan. And here we had the control group, type 2 diabetics with eGFR above 60 milliliters per minute. And the N is small, but still we found a difference, and we think that is one of the main mechanisms for why HbA1c goes down in the severe stages of CKD. So we did a study using CGM to validate HbA1c in hemodialysis patients, and we applied an iPro2 for 7 days at baseline and then every 4 weeks. And from that, we calculated a mean glucose. And then we measured fructosamine and HbA1c at the end that looks back at that period. So we could, it's a retrospective measurement of glucose that goes back 3 to 4 months. So we could compare those two ways of assessing glucose levels. And we included 36 control subjects with type 2 diabetes and eGFR above 60 milliliters per minute. And then an hemodialysis group also with type 2 diabetes. And here you can see on the y-axis we have HbA1c and the mean sensor glucose from CGM on the x-axis. And the dark ones are the control subjects. And here we have the hemodialysis patients. And you can see if we have 10 in sensor glucose, they have a lower HbA1c in hemodialysis compared to the control subjects, and we found a mean difference of 7.3. So when they are on 40, maybe in real life they are on 47. So then you can ask, is that a clinical significant difference? I mean, if they are just underestimated by 7, but there are also some of them there's a variation here. So some of them are underestimated quite a bit more, which I think is more clinical significant. And I don't know which patient is close to normal and which is severely underestimated. So that is a problem in terms of glycemic monitoring in this group of patients. Then we also included fructosamine, which is a completely different glycemic marker. It looks back in time 2 to 3 weeks. It measures the glycation of serum proteins. And here we have fructosamine on the y-axis and mean sensor glucose on the x-axis, and we found no difference between groups. So the hematological factors affecting HbA1c has nothing to do with fructosamine. So in this context, it looks like a promising marker, but there are some problems I will get back to. So what about, so this was hemodialysis patients. So what about the other CKD stages? So there are not so many good studies, so I'll show you this one. So they had a control group of 104 non-CKD patients, 14 with CKD stage 3 and 40 with CKD stage 4 and 5. This is a little difficult figure, I think, but here you have sensor glucose from CGM, which they use for 3 months here on the y-axis, and HbA1c on the x-axis. And if you look first at the non-CKD line, which is this one, the dashed line, and then the dotted line, which is CKD3, they are pretty similar. So it looks like the sort of the mild stages of CKD does not affect HbA1c compared to control subjects. But if you look at CKD stage 5, which is the straight line, there's a difference, which is in line with my findings. So I agree with the KDIGO guidelines as stated that it's the more severe stages of CKD and where HbA1c is affected, and not so much from 3, 2, and stage 1. Then we also have glycated albumin, which is actually used quite a lot in Japan and in the East, but not so much in Europe and the United States. It measures the glycation of albumin, and albumin lives something like 2 to 3 weeks, so that's why it only reflects glucose for 2 to 3 weeks. Then I use fructosamine, which is very much like glycated albumin. So 70% of the proteins that we measure in fructosamine is albumin. So they are very related. They have different units. So in albumin is reported in percent, and this one is reported in micromoles per liter. So what are some of the challenges with these markers is, for instance, if patients have proteinuria, so if they excrete a lot of protein, the liver, to compensate for albumin loss, increase albumin synthesis, and that means that you can also dilute down. They will excrete more unglycated albumin, which can also affect these blood samples. So then we have continuous glucose monitoring, which has been around for something like 20 years. So basically works by an intradermal sensor. You have the device applied to the skin. It measures interstitial glucose that equilibrates with blood glucose within minutes. That is why it is a surrogate marker for blood glucose or plasma glucose. And there are different models. There are the retrospective ones, which are the blind models, well suited for research, because that's what I used. So it stays there for 7 days. The patient do not know what happens, and I can get the readings at the end. Then there are real-time CGMs where the device is on the skin and the results are sent to the mobile phone, and the patient can see all the time what happens. And then you have intermittently viewed CGM, where the patient has to, if the CGM is applied to the skin, they have to flash with a cell phone or receiver to get the results. So those are different categories. And I just wanted to show you a few of the models. So first I can show you the one I used is the iPro 2. It was the blind model. What was a bit annoying about that model was that it required calibration, which means that the patient had to measure glucose on the finger 3 times a day to calibrate the device. Modern CGMs do not need calibration, and I think actually Medtronics are withdrawing their CGM from the market because their models are a little behind the other companies. Then you have the Dexcom G6. It can stay there for 10 days, and it can provide alarms. So if the patient becomes hypoglycemic or hyperglycemic, it can send an alarm to their cell phone, which is pretty smart, and it provides real-time data. Then you have the Freestyle Libre, which I think is used quite a lot, but you need to flash it every 8 hours, otherwise you lose data. It also comes in a blinded professional model that you can apply for 14 days, and then you measure glucose every 15 minutes. And then they can take it off, put it into an envelope and mail it to you, and then there are 3 weeks of batteries on it, and then you can get the readings. So I think it's also well suited for research. It's not very good at detecting hypoglycemia, so if you're doing studies on that, it's not the best model. And then there's one from Ruben Medical. Ever since a bit like a loop recorder, you install the a device underneath the skin, and it can stay there for 6 months. And then you have a receiver on the skin, and then that can transmit the results to a cell phone also. So there are different models with different advantages. So this is an example of CGM curves. So here on the y-axis you have sensor glucose and time on the x-axis, and each line represents a day. So you would also get like specific days. You can see what is the glucose. But if you see the dotted line, that is the mean glucose. You also get other metrics I'll show you in a minute. But you get sort of really nice intuitive curves, I think, of the glucose levels. And the iPro 2 measures every 5 minutes, so that's 288 measurements per day. And if it stays there for 7 days, that's more than 2,000 measurements, so you get a lot of readings. And you can also get it in an Excel spreadsheet where you take it out and you can use it for statistics and use data as you like. All right, so how do you interpret CGM data? So when I started with it was a bit confusing. There was a lot of different metrics, but fortunately there were published some simplified guidelines, which I will show you. So these are from Diabetes Care, and what they recommend is that you get 14 days of CGM readings in order to describe HbA1c and other things you want to perhaps do research on. You can calculate the mean glucose value. You can look at what is called glucose management indicator. It's an HbA1c derived measure. So from the mean sensor glucose, you can put it into an equation, and then you can convert it into an HbA1c like value. You can get it in percent or in millimoles per mole. So that's a familiar value, I think, for a lot of people. Then you can calculate variability, and here the suggests CV is the coefficient of variation, which tells something about the risk of hypoglycemia. And there's a cutoff value of 36%. You should be below it. Above it, there's an increased risk of hypoglycemia. And then there's what I think is an interesting area, what is called time in ranges. So you can take all these readings, 2,000 readings during a week, and then you can divide it into the time that the patient spends in different glucose intervals. And the aim of that is to spend as much time as possible in time in range, which is from 3.9 to 10.0. And you want to avoid time in hypoglycemia and hypoglycemia. And they also published some guidelines suggesting targets for time in ranges. And you can see these are for type 1 and type 2 diabetics, and they suggest to spend more than 70% of your time in target range 3.9 to 10.0, and then also allowed to spend a little bit of time in hypoglycemia. But these are not for CKD patients. There are different guidelines for CKD patients. So they suggest older, high-risk patients with type 1 or type 2 diabetes should spend more than 50% and less than 1% in hypoglycemia, and more than or less than 50% but more time in hypoglycemia. And I think this reflects also guidelines in the KDIGO, where they suggest that it's okay that HbA1c goes up as the kidney function deteriorates. And the reason for that, I think, is the fear of hypoglycemia in these patients. So I think one study that has made an impression is the ACCORD study that you may know. That was 11,000 patients with type 2 diabetes with a previous cardiovascular event or cardiovascular risk factors, and they were randomized to intensive control versus their standard group. And those who were treated with intensive glucose lowering therapy, they had an increased mortality. And the mechanism was not really, is not well known. It may be that hypoglycemia releases catecholamines that may produce an arrhythmia. That is one theory, but we do not know. But that is sort of the concept of thought here, I think, for the CKD patients, that we do not like hypoglycemia in this group. We think it may induce something really bad to the patient. Okay, so what is the advantages of CGM compared to HbA1c? So I just want to give you an example. So this was the curves I showed you before, that we had a mean sensor glucose of 8.1, and in this patient, here you can see there was no readings below 3.9, so no hypoglycemia. But then another participant in my study had almost the same mean glucose, and they would have the same HbA1c levels. But if you look at the curves intuitively, you can see here you have hypoglycemia. And the top one, I would feel confident increasing anti-diabetic therapy. I think it would go well. But in the patient below, I would feel unsafe increasing insulin. I think I would induce more hypoglycemia. So I think that is an advantage with CGM, that you can demask patients who has got hypoglycemia, and you can detect those who do not have hypoglycemia. So you can differentiate your treatment more. Then we have fructosamine and glycated albumin, and I just showed you that they were similar for the haemodialysis group and control subjects, but there are some problems with those markers also. So, for instance, proteinuria are very common in CKD patients, and we do not really know how that affects these blood samples. Another problem is that unlike HbA1c, where we have the IFCC standard in millimoles per mole, that means that an HbA1c in Denmark and England is exactly the same, but in fructosamine and glycated albumin are analyzed different in each lab. So we do not have sort of an international agreed reference interval, and the cutoff for diabetes is also varying from lab to lab. So there are some problems, and also things like inflammation. We do not exactly know how that interferes with these. So I'm not really sure about the future of fructosamine and glycated albumin. I mean, CGM is rolling out and becoming more accurate and cheaper, and so I'm not sure if that's the future in glycemic monitoring. Then we have self-monitoring of blood glucose, which is very classical approach to glycemic monitoring, but CKD patients and dialysis patients, they have a very high degree of comorbidity, a high degree of fragility. And in my experience, they find it extremely difficult to perform daily capillary measurements. So it's not an ideal way to monitor them either. And then we have time in ranges, which I think is a great concept. It has the advantage of maintaining glycemic control while avoiding hypoglycemia. So I think if somebody had the energy to make a study randomized to time in ranges, and then standard control, and see if that would make a difference, I think that would be a great study. And then I think I'll try how to implement CGMs in severe CKD and dialysis patients. So, for instance, the app of the Freestyle Libre, you have to apply it yourself, you have to flash it, and you have to look at your cell phone, and you have to interpret data yourself. And I think a 70-year-old, 80-year-old dialysis patient would not be able to do that, I think. For a lot of them, it would be very difficult. So a suggestion would be a periodic use of CGMs where you apply it maybe every 6 months for 10 days, and then you use that to assess glucose levels. It would also be more cost efficient. All right, so to answer the title question, from glycemic markers to direct glucose measurements, well, I think a great limitation for CGM is their cost. They're quite pricey. For instance, the Freestyle Libre is something like 2,000 or 3,000 euros per year. And I think a lot of countries would not be able to afford that to the general population. And HbA1c, despite being unreliable, does provide an indication. But I predict that maybe in the next KDIGO, the guidelines in 5 or 8 years, they will write that if CGM is available, it should replace HbA1c, but I think HbA1c will stay, but I think CGM will take over. But I think it will be a paradigm shift. I mean, if you ask an endocrinologist to not look at HbA1c at all and solely focus on CGM, I think it would be very difficult to leave HbA1c behind. And also in studies, I've seen the first protocols with advanced CKD stages where they use CGM as endpoints, and not glycemic.
Thank you very much for your nice presentation. Yes, and now many questions in the audience or any comments?
Thank you for a very nice talk. Are there any data looking at time in range and risk of long-term complications? And second question is, in the ACCORD trial, that was intensive treatment with insulin, right? So do you think the risk of hypoglycemia would be less with the newer glucose-lowering drugs?
So, yeah, the last question is right, the ACCORD study was not with CKD patients, so maybe it's unfair to take a non-CKD study and extrapolate to CKD patients. And I completely agree that if we use GLP-1s or SGLT2, we would not have so much hypoglycemia. But the problem is these drugs are not approved for hemodialysis patients, for instance, or PD patients. So in those groups, we use insulin primarily. So there's a lot of hypoglycemia. It's a big problem. And what was your first question?
If there are any data showing time in range and risk of long-term complications, if it's a better marker for example, cardiovascular risk or risk of microvascular complications than using HbA1c as a marker?
Yeah. So I've primarily studied time in range in relationship to dialysis patients, and there are no studies really going into that field. And I'm not so much into the literature on non-CKD patients, but I see it being used a lot. So I think there's evidence showing that it's a good way to address the glycemic levels. So yeah.
Okay. Are you using this measure in the clinical practice today?
In the Department of Nephrology, we are not, no. But I'm trying to. Now Bo has left, but I'm trying to push him into doing so. I think it would be great to do it, for instance, every 6 months. So dialysis patients, they have a status made every 6 months, and I think it would be great to do it there. So yeah.
Well, thank you. Very interesting. Do you have any idea? Now we have new ways to look at glycemic control and also to look at the excursion or the variability. If there are any difference if we look at the variability and the excursions in means of the disease progressions in kidney failure?
As I understand it, also variability. There's a big review in Lancet where they describe that there's no real evidence for variability in terms of long-term complications. But it makes complete sense that if you have a large degree of variability and a lot of hypoglycemia, it's not gonna go well for you. So but it's an important area, I think, to study. And also there used to be a lot of different metrics to look at. Now it has been narrowed into coefficient of variation and standard deviation. But regarding standard deviation, there are no reference intervals established. So it's kind of difficult to, when you see a standard deviation of 3, it's a little difficult to know if that's a lot or it's not too, yeah. So there's a lot of research to be done in the field of variability, I think.
Yeah, and also regarding the disease pathophysiology, looking at glycated albumin is also, from this can see is interesting regarding the glucose control, but also the pathophysiology would it be able to go this way regarding pathophysiology and knowing more about the disease progression and not just to titrate the right treatment? If, for instance, advanced glycation end products could be the more advanced part of glycated albumin, and you would figure that out earlier on, if it makes sense.
Yeah, that was a difficult question. I primarily looked at glycated albumin as a marker of the glycemic status. So yeah, yes.